My name's Ricardo Gonçalves. I'm a presenter on SBS, and I'm just moderating this session today. What we're going to do is we've got two speakers today. We're running a bit late, but they'll have their full 15 minutes to have a talk. And then for the following 10 or so minutes, we'll have a bit of a Q&A. So please send through your questions. I do encourage it. And we're here to talk about systemic racism in health. Before that, though, I'd like to acknowledge that we meet on the unceded lands of the Wurundjeri Woiwurrung people of the Kulin Nation here in Naarm. I acknowledge and pay my respect to the traditional owners and elders as the custodians of country and culture, and value the knowledges, perspectives, practices, cultures and traditions of First Nations people. Going through a pandemic, obviously we all know health is of extreme importance, and it was really highlighted, but also what's been highlighted, I guess, are some key issues, including equal access to health and the barriers preventing that from happening. And one of them, which we'll explore today in detail, is that systemic racism. So the community groups that's going to be impacted by it, we'll talk about that. The multicultural workforce, and of course what can be done to improve it. Our two guests today are Danella Mills and Dr. Chris Lemo, and we'll start with Danella. You may have noticed there's been a bit of a change in the program. Danella replaces Pat Turner because Pat's attending Justice Brendan's funeral, and she sends her sincere apologies. Danella Mills is the chair of the National Aboriginal Community Controlled Health Organisation. She's a proud Torres Strait Islander woman with ancestral and family links to Masig and Nagi. She's chair of the National Aboriginal Community Controlled Health Organisation, chair of Bicultural and Health Service, a member of James Cook University Council, and was recently appointed to the Commonwealth Government's Advisory Council on Family, Domestic and Sexual Violence. From 2014 to 2021, she worked as a Cairns-based lawyer, where Kim Kardashian is at the moment, I read this morning, in Cairns, with Law Right, a community legal centre which coordinates the provision of pro bono services for vulnerable people. She was also the managing lawyer for the innovative Bicultural and Health Justice Partnership, in which lawyers and health professionals partnered to achieve improved health, wellbeing and justice outcomes for Aboriginal and Torres Strait Islander people. In 2020-21, she served as the Partnerships Director at Health Justice Australia, and in August 2021, she was appointed Senior Associate Pro Bono Manager at King & Wood Mallesons. Please welcome to the lectern, Danella Mills.
Good morning, everyone, and good morning to my fellow panel member, Dr. Chris, and thank you all for allowing me to step up while my wonderful CEO is also got major commitments on today. My name is Danella Mills. I'm the chair of Bicultural and Health Service, and I'm extremely proud not only to be the chair of Bicultural and Health Service, but to be the chair of the National Aboriginal Community Controlled Health Organisation, NACCHO. As you heard, I'm also a lawyer at King & Wood Mallesons, and having that focused lens on justice helps me do my work day in, day out. Before any of those positions and titles, I am foremost a First Nations woman. I'm a Torres Strait Islander woman with ancestral and family links to Masig and Nagi. I am a First Nations mother, daughter, sister, aunt and cousin. I too want to acknowledge the traditional custodians of the lands where we are meeting today. We're on the lands, the home of the Wurundjeri peoples of the Kulin Nation, who for many thousands of years have taken care of the place now known as Melbourne and its greater region. The Wurundjeri peoples have intimate knowledge of their lands and waters, flora and fauna, seasons and weather. I also want to acknowledge all Aboriginal and Torres Strait Islander peoples here today. The Wurundjeri peoples, like my family and all First Nations peoples, were protectors, carers and healers, providing for the health and well-being of our families, our communities, our country and our ongoing cultures. We've been looking after the health and well-being of our peoples for more than 60,000 years, so that our peoples not only survived, but thrived on our lands. I say this as it's extremely important that when we are talking about today's systemic racism in the health system, that we understand two fundamental points. The first point is that Aboriginal and Torres Strait Islander peoples are foremost and always Aboriginal and Torres Strait Islander peoples. We have our own distinct identities, languages, and beliefs about what contributes to health and wellness and what causes sickness. Australia's health system, however, is built around the identities and beliefs of the white settler and their Western model of health and wellness and causes of sickness. This immediately puts Aboriginal and Torres Strait Islander peoples on the back foot in accessing healthcare in Australia. For us to access mainstream health services, we are required to suspend our own beliefs and cultures and adopt or even try to accept the Western model of health. We need to put our languages aside and speak in English and in technical terms, or where there are hidden meanings in various discussions. This puts many of us in great internal conflict, where we do not feel recognised as Aboriginal and Torres Strait Islander peoples, and where our views on health and wellness are not accepted. There is no starker example of this than in the Northern Territory, where too many Aboriginal peoples are required to move to regional centres away from their homelands, their country, their families, just to be able to access renal dialysis. For Aboriginal and Torres Strait Islander peoples, our wellness is drawn from our country, our lands, and being connected to our kin. Whilst accessing life-saving renal treatment in a regional centre is good for our kidneys, many Aboriginal peoples feel a deeper sickness that goes to our very being. The consequences of leaving country and kin include grief and loss, and we're unable to fulfil cultural obligations, and our spirits become sick. The deep sickness can be so strong that many Aboriginal peoples choose to stay on country, choose to stay with their family and kin and keep their spirits whole whilst their kidneys fail. This notion that Aboriginal and Torres Strait Islander peoples are accessing healthcare provided within a Western settler model may not, on the face of it, seem like systemic racism. In reality, it is an act of continuing colonisation against my people. We are continually asked to set aside our Aboriginality, our race, in order to access the health services we need. This is one way systemic racism works within our health system. The second point, which is far more light, that I wish to make, and one that you are all familiar with, is how general racism towards Aboriginal and Torres Strait Islander peoples results in assumptions and attitudes that lead to bias in the safety and quality of healthcare. Racist views that we are responsible for our poor health outcomes and illnesses, and that we already receive the lion's share of government funding. This leads to different decisions from practitioners about our care and different decisions that they would make for non-Indigenous Australians. This often translates to less access to the healthcare we need, where individual practitioners and health services make decisions around who is deserving of treatments, occasionally withholding necessary treatments and delaying interventions. We can be left to wait to be seen in emergency departments. We can be left off waiting lists for life-saving treatments and organ transplants. We can be provided with limited treatment options where there are more options available. We can be characterised for life situations and illnesses that are beyond our control. And we can be talked over and not a full participant in our own care decisions. And at its worst, our health needs can be ignored to death. The consequences of these interactions and the way we are dealt with are twofold. Firstly, there are poorer health outcomes for Aboriginal and Torres Strait Islander peoples than non-Indigenous Australians when we engage in the mainstream health services. Secondly, these experiences can understandably lead to Aboriginal and Torres Strait Islander peoples delaying seeking care, avoiding engaging with health services when needed, and not following up on needed appointments and treatments. Again, this all contributes to poorer health outcomes for my people. These scenarios apply similarly to other Australians who are from non-dominant backgrounds. Your own cultures and beliefs are often not supported within the mainstream healthcare system, where their own health and wellbeing practices are not properly understood and accepted. And Australians from culturally and linguistically diverse backgrounds also need to grapple with embedded racism in accessing and making decisions about any health services. Aboriginal people's response to systemic racism in the healthcare system and an unmet need for culturally safe and accessible primary healthcare was to create our own health service. The first Aboriginal community-controlled health organisation, or ACCHO or ACCO, depending what up end or down end of Australia you're from, was established for local Aboriginal and Torres Strait Islander communities in Redfern in 1971, more than 50 years ago. And ACCHO is a primary healthcare service initiated and operated by the local Aboriginal community to deliver holistic, comprehensive and culturally appropriate healthcare to the community which controls it through a locally elected board of management. And ACCHO is mostly staffed by our own Aboriginal and Torres Strait Islander health workers and provide flexible and responsive services that are tailored to the needs of our local Aboriginal and Torres Strait Islander communities. In line with the Aboriginal concept of health, ACCHOs support the social, emotional, physical and cultural well-being of Aboriginal and Torres Strait Islander peoples, families and communities. To be crystal clear, there is no other way of delivering healthcare in Australia that provides Aboriginal and Torres Strait Islander peoples with a level of cultural safety, cultural identity than an Aboriginal community-controlled health organisation does. We now have more than 145 ACCHOs operating across Australia. Many are in places where there are no other health services. Others are in metropolitan centres like here in Melbourne, providing a culturally safe alternative to mainstream care. A national umbrella organisation for ACCHOs, the National Aboriginal and Islander Health Organisation, was first established in 1976, and now we know that that organisation is NACCHO, the National Aboriginal Community Controlled Health Organisation, in 1992. NACCHO has affiliates in every state and territory, providing guidance to ACCHOs and advocacy on their behalf to governments and other healthcare providers. The results are really, really clear and they speak for themselves. Through our ACCHOs, Aboriginal people are more likely to access care in a timely way, receive the services they need, follow up with any treatment and additional care, and achieve better health outcomes all round. As we look to the future, there are 3 important steps to take on a pathway forward. The first is to continue to expand our own services through the creation of additional ARCHOs and expanding the capacity of some of our smaller ones. We need a particular focus on places where there is currently limited access to health service, or the only option is a mainstream service, and there is a high population of Aboriginal peoples living in that area. The second is through the proper funding. Just want to really underscore funding of our ARCHOs and for Aboriginal and Torres Strait Islander health more generally. Our ARCHOs are funded by the Commonwealth Government, and this has over time improved, but we have still to this day continuing to work through chronic underfunding for decades since our inception more than 50 years ago. The current funding model does not properly recognise our comprehensive model of care, the challenges in providing care services in remote and very remote locations, and the complex health needs and complex social needs of our people. The lack of recognition of the work that our ARCHOs do and our underfunding is another example of systemic racism in our healthcare system. If we are to break down the systemic racism that exists in our healthcare system, we need proper funding for our ARCHOs, as our ARCHOs are the main mechanism to provide culturally safe care to our peoples. Now, I know that I'm limited for time, so I might just skip a little bit about how much money we actually need, because everyone in this room knows that funding needs to be based on need. Funding needs to be based on the challenges of geography, the challenges around the burden of disease. My final point that I wanted to make is, for those here in the room that represent a health service, what I would say to you is it is so important that you identify your local Aboriginal community-controlled health organisation and seek to partner with them. I encourage each and every one of you to take this message back to your workplace, to deeply connect with your Aboriginal community-controlled health organisation, build a relationship that is based on trust and loyalty, and that will assist in the delivery of a culturally safe practice. And if you are here today, which we all are, considering actions to tackle systemic racism in the healthcare system for other culturally and linguistically diverse Australians, there are so many lessons that can be drawn from our ARCHO model. And we are really, really keen to partner with you and to exchange knowledge and to share learnings together. In taking these 3 steps, we will help ensure that access to a health service is culturally safe, and that our beliefs of health, wellness and sickness are recognised as strong cultural determinants of health, and that we all receive appropriate health care without any forms of racial judgment. Thank you.
Thank you, Danella. I think later in the Q&A we'll be talking about some of those shared learnings and how that can be passed on. We're also getting some questions come through, so if you do have some questions, please send them through. I'd much rather go through the questions that you would like to ask than the preset ones I've got here, so that we address what you want to know. Next, we'll be hearing from Dr. Chris Lemo. Chris is an infectious diseases and general physician, currently Head of General Internal Medicine at Western Health in Victoria, and has worked in refugee health. He's a strong interest in the impact of intersecting social inequities on health and well-being, particularly chronic illness, blood-borne viral infections, and sexual and reproductive health, and has published a significant body of work of research in these fields. He served on the board of the Australian Federation of AIDS Organisations, is a member of the National Ministerial Advisory Committee on Blood-borne Viruses and Sexually Transmissible Infections. Chris was founding president of the Victorian African Health Action Network, and he is a member of the interim coordination group of the new Australian Multicultural Health Collaborative, officially launched at this conference. So at the lectern is Dr. Chris Lemo.
Thanks very much, Ricardo, and thanks very much, Danella. That was a wonderful speech, and really great to hear all of those things being said. I'd just like to begin by acknowledging the country that we are on, the country of the Wurundjeri and Wurrung people of the Kulin Nations, and pay my respects to their elders, past, present, and the leaders who are coming up. It's such a privilege to be able to speak here with the blessing of the people who really own this land. Also like to thank FECCA for the invitation to speak, very humbling and rather shocking invitation, so thank you very much for that, and acknowledge all of the distinguished guests here present. Just as a disclaimer, anything that I say is my thoughts, my opinions. Don't blame any of the organisations that I'm associated with for anything I say. So why systemic racism or structural racism in healthcare? Well, simply, our race, ethnicity, culture and language shapes our interactions with the healthcare system in Australia. Whether we are working in that system, whether we are patients or clients of the system, or whether we are members of the communities from whom both workers and patients come, our interactions are shaped by that overwhelming structural racism which we are in. Race is one of the social determinants of health. But racism is one of the political determinants of the social determinants of health. And I think it's really important that we understand that racism creates race. Racism, I kind of think of it as a system of thought that tries to make our complex world simple enough for racists to understand. When you see those boxes and which box you tick, and you realise that you could be in either one, and do you fit in the space between? And you realise that your identity, your history, your relationships just aren't reducible to those neat categories. And that's the experience that so many of us find with every form that we feel, with every interaction that we have, again, whether we're working or using the services. Racism labels differences arbitrarily, it assigns them importance, and it defines a group by the presence or absence of those differences. It then attaches stereotypes and prejudices and presumed characteristics of that group. It treats those members of those group as members of the group and not as individuals in their own right. It's dehumanising at its very core. And it assumes that the differences are peculiar to that group and that they are passed down from generation to generation. So it is premised on intrinsic inherited difference. And that's why when you hear people say, oh, Muslims aren't a race, so I'm not racist if I'm against Muslims. You are. You are being racist because you are assuming that it's an intrinsic capacity, the characteristic that's passed down from generations, and you treat people based on that. Racism is not the same as ethnicity. They're both very muddy, ill-defined concepts, even though they're so all-pervasive. Ethnicity is more clearly cultural. Racism can be biological, it can be cultural, it's very plastic, it's very versatile, can be fit to many purposes. Most of those purposes are not good. So structural racism isn't a bigotry, it's not prejudice, it produces bigotry and it produces prejudice. It's a social system. It's part of our mental furniture. It's part of medicine, it's part of science, it's part of art, it's part of culture. It's hard to avoid because we're in it all the time. We're born into it, we grow up within it, we are indoctrinated in it in our schooling, in our home, in our religious upbringing. It's very hard to avoid labelling, categorising people, and then ranking them in terms of their value and their usefulness or their threat. In scientific research, that way of approaching things shapes the questions which research can ask. It shapes the way that people are recruited. It shapes the way that the data is recorded and analysed, and the conclusions which are drawn, and then the reporting, which then becomes scientific evidence, which is then the basis of practice. So when you hear evidence-based practice, evidence-based medicine, the racism is baked into it from the very beginning. In the clinical space, we assess the risk of various conditions which might be present or people might develop in the future. And a lot of what we do is shaped by those racist categories. And the tests that we request, the way we interpret those tests, the medications we prescribe, are all imbued with that unfortunate structural problem of scientific racism. And the way we communicate in clinical spaces, and as we are all too aware, in public health, is also shaped by that way of thinking, of categorising people, assigning them to their different categories, and then trying to approach them, down the list of, most important to least important, least vulnerable, most vulnerable, and it shapes everything that plays out. And I would say probably everybody in this room has seen how that comes out, in everyday life, in your work, especially over the last couple of years. But of course, it's gone on for so much longer than that. In the health workforce, racism is extremely ubiquitous. It affects the recruitment, the patterns of who gets to get which job, which cultural groups predominate in particular professions, in particular places, how people are treated, both by their managers and also by their patients and clients. And racism, again, is an everyday part of occupational violence and aggression. Under stressful conditions, being ill is a very stressful condition. Being the family member of someone who's ill is a very stressful condition. And working in an under-resourced and overburdened system is also very stressful. And under stress, we tend to revert to our default settings of how we judge people. And if those default settings are racist, then that's what we will be. So the effects of structural racism, as Danella so clearly set out, are marginalisation. You might be neglected. You might not get a look in on the waiting list. There might be people who don't provide you the same treatment. You might not be listened to when your expertise and your knowledge are clearly relevant, but your face says you're not a person whose opinion needs to be heard. So marginalisation and exclusion, both as workers and as patients and clients, is a very common experience. The silencing, the people who know but don't say because they just don't want to fight that day. The stigma and discrimination which people attract by virtue of conditions being attached to their countries of origin, usually in a very derogatory fashion. I see WHO are trying to rename monkeypox because of various racist, stigmatising language which is being used. But of course, it's a very versatile system, and it will attach itself to whatever new label they come up with. And the waste of skills, the waste of knowledge, the waste of resources being devoted to things which actually don't address the priorities of individuals or communities is something that we see every day. So how do we respond to this? How do we respond to a system that is all-pervading and in which we are in? Well, reality is a good place to start. Australia is a culturally and linguistically diverse society, has always been, from the beginning of the settler colonial project and well before that. Hundreds of distinct linguistic and cultural groups with their worldviews, rich traditions and understanding of the world, were then overlaid with another complex of cultures in which one was dominant. So English is a dominant language, even though it's never been the only language. English isn't even the only language in England. Never has been. But somehow it seems to be normal, it seems to be the mainstream because it's dominant. We need meaningful inclusion of everyone who is concerned in health, which is everyone. And that needs to be from the very beginning, from the planning to the execution to the evaluation of any project. We need to actually include all of the voices in the conversation, and the last word should always go to the people who are most deeply affected. And we need some structures and processes to make sure that that happens. We need to pay attention to power, the power dynamics in the room and around that planning table. It's not enough to be at the table, you have to be able to speak, and you have to be able to listen. Malcolm X said, because I'm at the table, does that make me a diner? I'm not a diner until you let me dine. Which brings me to probably the most important group of people in this whole messy, complex problem. Again, in my opinion, bicultural workers. The people who stand between the system and the people who stand between communities and the institutions, the people who mediate those different ways of organising life and seeing life, are uniquely placed to mediate those conversations. They have knowledge, they have skills. They have linguistic skills, they have technical skills, and they have the mental habits of seeing different worlds simultaneously overlying each other. And those of us who are from culturally mixed backgrounds or who work, who've lived in other countries, know how that frame of mind shifts when you're going from one to the other and back again, and you see the same things differently. It becomes second nature. And it's not until you talk to somebody who has never had to do that in their life that you understand that it's actually a skill. And the trouble is, there are people who don't have that skill, don't recognise it as a skill, and don't value it. And they are the people who are usually calling the shots and signing off on the budgets. So another name for structural racism or systemic racism is arrogant ignorance. I don't know. I don't care. I don't see it, it's not there. And when you challenge it, that arrogant ignorance becomes belligerent ignorance. And you really know when someone's trying to shut you down. At the moment, bicultural workers are essentially treated as native trackers in a colonial system, whether that's health or education or justice. Do a lot of the work and get things done, but in a subordinate position and not usually remunerated for the work they do, and fighting a battle every day against a system which is quite intrinsically hostile to them, but staying there in order to advocate for the people they care about. And those are the people who are their clients and patients, but also their co-workers. I mean, you can't work with people that you hate every day, it'll kill you. And you can feel sorry for someone who's making your life hard just by the virtue of the fact they don't see what you can see. But eventually your tank runs out and you have to leave. And that's what the burnout looks like. So I think bicultural workers have a potential to be literally the foundation of Australia's primary health system. If you really want to find out how to keep people well, ask the people who know. Ask the people who know the people who get things done and who are aware of all those social networks and those local factors and can translate that into the language that an institution understands. But they need recognition, they need remuneration, they need prospects for career progression, and they need to be able to lead rather than follow. There are challenges with that, moving towards that. Bureaucratisation is an ever-present challenge of yet another set of forms and yet another set of criteria and competencies and administrative burden on everybody. And of course there is a cost. There is a cost to that. Someone has to pay for it. But we're already paying for its not being done. We're paying not just money, we're paying in lives, we're paying in suffering, and we're paying in the lack of potential, which is just going to waste. So we need respectful relationships to get this going, and we need a rich dialogue that enables reflection and understanding of the complexity and what actually are the priorities. What are the aspects of a person's identity which are relevant in that time, in that place right now to keep them well? Whether that's in the street, in the clinic, in an office, in Parliament. We have people who have knowledge, and we do have the relationships, but what we don't yet have is the political will to commit to paying for the work which is already being done and the work which needs to be done to develop a truly equitable healthcare system in Australia. Thank you.
Thank you, Dr. Chris. We've got a few moments only, so I'm going to bang through the questions that are coming through. So if you do have any pressing questions, get it through the Slido platform. One of the first ones, and probably on the more positive side, right, for the panellists, do you think the pandemic has led to any positive changes in the delivery of health services for First Nations and multilingual communities?
Can you hear me? Oh, yes, it is. Great question, whoever put that forward. So what the pandemic has, without any shadow of a doubt, proven is that Aboriginal community-controlled health organisations, we know what we're doing. And when I say we know what we're doing, the data tells a very clear story that when you look at the catastrophe and the chaos of the pandemic, it was our archos that knew what was needed on the ground. We were able to mobilise, we were able to protect our communities so quickly. And so, again, when we talk about the power of community, the power of people, the power of bicultural workers, the power of Aboriginal and Torres Strait Islander health practitioners, it is those individuals that know what communities need. So what we are trying to do at NACCHO is really but the pandemic is just clear evidence as to why our model is the best for our people, why we've been able to do so successfully when our burden of disease is 2.3 times higher than non-Indigenous Australians. How have we been so successful? Because we know how to care for and protect our communities.
Yes. Dr. Chris?
Thank you. Yes, and I think Aboriginal and Torres Strait Islander people really led the way in the response to the pandemic. They were the first to develop a really comprehensive plan, put it into action, and very successfully. I think the relationship between government, health system and community has been highlighted in the pandemic, and the role of community networks and the people who work in those networks, and particularly bicultural workers, has definitely been highlighted by the pandemic. It's not new, it's been the case for decades. But I think one of the things about COVID is that because of the way it spreads and because of the disease and because of its relationship with chronic disease, it has enabled people to see the relationship between those social determinants of health and the outcomes in a time frame that is within our attention span. And I think that's the main difference. It's bigger and it's faster, so we can actually see what was there all along.
We've got quite a few questions and we're running out of time, right? But I want to leave the last moment with both of you, because you're the ones working in the field. You're the ones that knows what's going on. What's the one key message you want to leave with this morning?
Oh, goodness. Look, you were all here yesterday and you heard from Professor Megan Davis. There's so many things that I would want to offer to that question, but What is really, really important is for Aboriginal and Torres Strait Islander people to have recognition in this country. This country has existed far too long, and its intention to not deal with the unfinished business needs to come to an end. So I would say to each and every one of you, be champions of the Uluru Statement from the Heart. See it as a gift, not just for me or for you, it's for all of us. It's about resetting this nation. It's about moving together in a way that is about seeing each other, hearing each other, and working together for a better country. So that would be the one thing. Structural reform is key. Everyday people working with different levels of government, working with different corporations, we need to find ways of being able to find humanness. And a part of that is voice, treaty, truth. Thank you.
And Dr. Chris, final word?
All of what you said, to start with. For those who know, get together, organise and start speaking loudly and strongly. For people who are in government and authority, listen. Listen, think, and then speak, and then listen again. Thank you.
Thank you very much, Dr. Chris Lemo and Danella Mills. Thank you. If you both want to stay here, well, we may as well stay here. And I think we've got our next speaker. Just to give a very quick address, I'd like to invite to the lectern the Honourable Jed Carney, MP, Assistant Minister for Health.
Well, after that little dance across the stage, thank you very much, everybody, for having me. I would like to begin by acknowledging that we meet on the Wurundjeri and Bunurong peoples, the land of the Wurundjeri and Bunurong peoples of the Eastern Kulin Nations, and I pay my respects to elders past, present and emerging. And it is important every time you acknowledge country that it just doesn't become something rote, that we do. I am the federal member for the electorate of Cooper, which is named after the wonderful William Cooper, who was a great Aboriginal activist in his day. And I'm very, very proud to be the first ever member of that electorate because we changed the name from someone who I think was perhaps a little less prestigious than Mr. Cooper. I would also like to acknowledge other Aboriginal and Torres Strait Islander peoples with us today. Thank you so much for that presentation. I only caught the end of it, I'm sorry, but I could see that it was heartfelt, that it was emotive, that it was sincere and incredibly important information. So Danella, I don't think we've met formally, but it's a great honour to be here with you today. And Dr. Lemo, thank you very much, same likewise. I have seen so many times First Nations community and health groups do so much of the heavy lifting, and it's so important that when it comes to closing the health gap, that the gap actually still tragically exists, but it's so important that we have First Nations people leading the way to closing that gap. Now, this is something that an Albanese government wants to absolutely work on. I still can't get used to saying that because it is very fresh and I'm very excited about it. And an Albanese Labor government has appointed the wonderful Malandiri McCarthy, who is a First Nations woman, to be the first Assistant Minister for Indigenous Health. And we are very proud of that. And she, of course, will work with the wonderful Minister for Indigenous Australians, Linda Burney. I'm sure you know Linda Burney. And we will all work together. The whole government will work together with you and with all Australians to implement the Uluru Statement of the Heart in full. It's very exciting. I have my beautiful grandchildren here with me today. I have them on a Friday, and I was so proud to stand out in front of the actual statement and have my photo taken. And in 10 years' time, I'll show little Jack and I'll show little Florence that they saw that wonderful statement in the flesh, in real, and hopefully they will say, "What was all the fuss about, Grandma?" That's what I'm hoping. But it is a journey, and we are prepared with your support to see it to the end. Incredibly important. I'd also like to thank the Federation of Ethnic Communities Councils of Australia. Thank you, Mary and Mohammed, for having me here today. Congratulations to Carlo, who I believe is the incoming president. Am I allowed to say? It's announced, isn't it? Yes. Okay. Maybe I just let the cat Maybe I just let the cat out of the bag. It is a wonderful organisation, and as some of you might know, that before becoming a Member of Parliament, my background was in nursing and the union movement. I worked as a nurse for 20 years at the Austin Hospital, just here in Melbourne, and I worked across a whole range of areas, as many nurses do, from the acute sector, the aged care sector and the community sector. I was also Federal Secretary of the Australian Nursing Federation for many years, and then I became President of the ACTU, which was the job I had before I was elected as a Member of Parliament. And I had the great honour of working with FECCA as the President, mostly as the President of the ACTU. We collaborated many, many times, and it was an honour. So it's very lovely that I'm here with you this morning. Thank you. We've just now heard about experiences of racism, both at an individual level, excuse me, and also how racism can operate within systems and structures. And this racism, of course, it goes without saying that it makes it difficult for people to navigate what is a sprawling and complex health system and get the care they need. Now, I want to be really clear that our government takes a firm and decisive stand against racism in all its forms. And I know you heard from the Minister for Immigration, Andrew Giles, yesterday, is that right? Who this is something that ever since I've known Andrew and worked with him, this has been a driving passion of his. It's also something that I feel strongly about when it comes to Australia's healthcare system. And it's something I want to work on as the Assistant Minister for Health and Aged Care. And I have discussed this with the Minister Butler, and he and I are absolutely determined to make it a key part of what we do in government. During the COVID-19 pandemic, a lot of valuable lessons were learned about how particular communities engage, and we just heard a little bit about that. And sometimes, of course, they don't engage, which is very worrying with the health system. So it's important for governments at all levels. Health decision makers and health professionals need to listen to all groups. That's my baby, Florence, there. Sorry, everyone. My grandbaby, I should say. She's clearly not very happy. Thanks, Laura. To listen to all groups in our society to better understand their situations and act accordingly. Now, I'd just like to say a few words about First Nations healthcare before I speak about called communities. I think you've probably heard, and I'm just telling you what you already know, that a lack of cultural safety in mainstream services, including language problems, discrimination, cultural appropriateness, can prevent an alarming 1 in 3 First Nations peoples from accessing health services. We know that the greater health gains or benefits, that is up to 50%, can be achieved if services are delivered through art shows. In 2016, it was estimated that these health services served between a third to half of the First Nations population. That is extraordinary. However, many people are either unable to access such a health service because of their location or other barriers, or they choose mainstream primary healthcare services. This means that Australia's health services, particularly hospitals and specialist services, need to better understand the culture and needs of First Nations peoples. We can't just say, don't come here, go to an art show. We can't be culturally appropriate. We need to work together. This understanding will be key to achieving better health outcomes so First Nations Australians can live longer, healthier lives and receive the care they need. I'm very proud to say that in my electorate we have the Victorian Aboriginal Health Service led by Michael Graham there, a wonderful service which is domiciled mostly in Fitzroy, but I do have a campus, and it is a very exciting and wonderful organisation, and we're very proud to support it. Now, with respect to our wonderful called communities, there's also a lot more work to be done to address the needs of culturally and linguistic diverse people in Australia. According to the 2016 census, 45% of Australians were either born overseas or had one parent who was born overseas. It's worth noting that people born overseas generally migrate to Australia in very good health, because there are requirements and eligibility criteria to migrate here in good health. However, studies show that after 10 years in Australia, immigrants from non-English speaking countries have worse mental health and self-assessed health than people born here. How does that happen in one short decade? The COVID-19 pandemic brought into sharp focus the additional work that needed to be done to ensure CALD communities had appropriate access to information, to care and support. A new Multicultural Health Connect helpline is being trialled here in Victoria, which we're very proud of, the People's Republic down here. This helpline, funded by the Commonwealth Government and implemented in collaboration with the Victorian Government, was set up in response to concerns that people who speak other languages were not getting the right information and that interpreters simply were not available when they were needed. The new Multicultural helpline is managed by people with an understanding of different cultural backgrounds who will help callers with all the health information they need and help them navigate the health system. I look forward to hearing a lot more about this trial and the benefits it brings to CALD communities. I'm incredibly proud to be a strong voice for social justice issues in the healthcare system, including to make sure it's accessible, relevant, safe and fit for purpose now and into the future. And I want to finish by thanking FECCA once again for all their work and advocacy over many years. It's so important to hear the voices of FECCA and everyone else in this room. And I want you to know that our government, a Labor government, an Albanese government, is truly listening and wants to hear from you so we can work with you to deliver a better health system that gives everybody the care not only do they need, but is their right. Healthcare is a human right. Thanks very much, everybody. Okay.
Minister, thank you so much for joining us. It's wonderful to have you, and we look forward to working with you to advance multicultural health. It's very important. Thank you. I have to say, everything that FECCA has been able to achieve with our communities in the past couple of years around multicultural health has been because of our learnings from our First Nations people. So to them, we are grateful, and we look forward to working with you in the future. Now, I've got my friend and co-chair of the Australian Multicultural Health Collaborative, co-chair Marina Chan from World Wellness Group. This is why we're here, make connections. And we're here to actually launch the Australian Multicultural Health Collaborative. We heard about, I suppose, the need for a voice, a national voice to advocate on multicultural health. So I'm going to hand over to Marina to speak a little bit about that. And with the help of the Assistant Minister, we're going to launch this thing.
Yeah, it's great.
Well, good morning, everyone. And what a morning it has been. My heart is so happy. My name is Marina Chand and I'm from World Wellness Group. We are a social enterprise multicultural health service based in Brisbane. We're actually the people behind the helpline that the Minister just mentioned. I too would like to acknowledge that we are meeting on the unceded land of the Wurundjeri people of the Kulin Nation and pay my respects to elders past, present and emerging. I'm really honoured to be co-chair of the National Multicultural Health Collaborative. I never thought I was going to say these words after 30 years working in multicultural health. And it is a great pleasure to finally launch this collaborative here at the National FECCA Conference. In Australia, we absolutely and urgently need equity in the health system. We can only achieve health equity for our communities through collaboration across all sectors and across this country. As a working collaborative, we aim to provide a strong national voice, leadership and advice on policy, research, practice, data collection to improve access and equity and to achieve better outcomes in health for Australia's multicultural populations. The collaborative will be in a unique position to represent the voices of CALD health at the national level, representing the lived experience of CALD consumers, together with health practitioners, services, people working in research, and institutions whose primary focus is multicultural health. Multicultural Australia should not be treated as a fringe population or an afterthought or a minority issue. Multicultural is mainstream. We deserve health equity and we deserve health justice. This collaborative is our opportunity to make it happen. So I invite you to please join us. My colleague, Dr. Chris, just handed me our first document, which you can find at the FECCA booth, which is outside in the lobby. Please look us up, join us as a member. We are online already, multiculturalhealth.org.au, putting in a plug. Please join us. And it is also my pleasure to, together with Mohammed, to announce that there will be a national multicultural health conference next year in New South Wales. So please stay in touch with us, join us, sign up, and we really look forward to working together with all of you. So together, we announce that the collaborative is launched. Yeah. Thank you.
I'll just say a very quick congratulations. It's wonderful, Marina and Mohammed, and this is going to be such an important part of us working together and collaboratively going forward. I do remember when you become a new minister, you sit down and you get lots of briefings from the department. You know, they tell you lots of things, and some of my department colleagues are here. And it's kind of like overwhelming. But one thing that absolutely stands out for me was when they told me about the multicultural health team that you had supporting the government during COVID, and how things just turned immediately once they started to ask the people on the ground how it should be done. Funny about that, isn't it? Very funny. So I've heard what a great success that group was, and I look forward to continuing that wonderful work about how we can keep all of our communities healthy and strong. So well done. Congratulations. Thank you.